I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
74-year-old lady with a stage 4 invasive lobular carcinoma, ER and PR positive, HER2 negative. She is now status post bilateral mastectomy. Originally thought to have sort of curable disease, but later found to have osseous metastasis. And so currently receiving palbociclib and fulvestrant. And so the question that's being raised is the next recommended treatment option if she has progression at that time. So initially diagnosed in June of 2019 by mammography, subsequently having an MRI, which showed several concerning areas in the left breast, the largest of which was 4.2 centimeters. She had extensive left axillary and subpectoral lymphadenopathy concerning for metastatic disease, and a left chest wall 2.9 centimeter area concerning for metastatic disease. Subsequently, the PET scan in 2019 showed multiple healing rib fractures, which at that time were attributed to an MRI accident. Unfortunately, I haven't ever seen that happen personally, but where a strap was caught while trying to advance the patient. So those rib fractures were not initially thought to be pathologic, but more so attributed to this trauma. She subsequently then in the next February had a PET scan, which did demonstrate the presence of bone metastasis. And then the subsequent October had a repeat PET scan, which showed solitary small hypermetabolic anterior left pelvic osseous metastasis, resolution of the uptake involving the remainder of the previously described hypermetabolic osseous metastasis, and no evidence of sort of extra osseous metastatic disease. So really bone-only metastatic disease. And importantly, this patient has not undergone genetic testing. The pathology here, as you see, strongly ER/PR positive and HER2 negative. We can see here some of the imaging findings, and I think in the interest of time, we'll progress to.
I want to go back to one image on the last PET because the description is she only has one hypermetabolic lesion left. But if you take a look at her lumbar vertebral body, and I can't tell you which one it is, but there is definitely another area of abnormal uptake. So she at least has two lesions that have come up that apparently she sounds like she has a heterogeneous response, but there's definitely that second lesion, and it's important to note because it looks like it could be impinging on the epidural space. So
thank you so much for pointing that out. So her initial treatment had included neoadjuvant, cyclophosphamide, and docetaxel. And then upon diagnosis of metastatic disease was started on palbociclib and fulvestrant. And would like to elucidate recommendations from you all about the next recommended treatment option at which time she experiences progression. So of course, we would recommend genetic testing as a part of her stage 4 workup to see if she's a candidate for PARP therapy. And Dr. Pegram, do you want to comment what would be your preferred choice of next therapy?
What one needs to understand in a case like this is her PI3 kinase mutational status. So I would look at one of her tissue, probably the most recent biopsy that's available in this case, particularly if she has a metastatic biopsy available, and look at the PI3 kinase gene sequence If it's mutated, then she could consider an Alpelisib-based regimen following progression on fulvestrant and a CDK4/6 inhibitor. The FDA-approved regimen is actually in combination with fulvestrant and Alpelisib. I note, though, that she's already on fulvestrant. In order to get this covered by insurance, you may need to continue the fulvestrant and just simply layer in the Alpelisib. That would be one option. And if she couldn't tolerate that for any reason and you wanted to switch to a different endocrine agent, you could switch at that point and try an AI, for example, which she hasn't had at least for a while. If the tissue specimen doesn't show evidence of a PI3 kinase mutation, that doesn't necessarily rule out the possibility that she has one, particularly in light of the fact that these mutations can be acquired through the life of a metastatic patient. So if the tissue diagnosis is a wild type for the PIK3CA gene sequence, then I would do a circulating tumor DNA assay like the Garden 360 assay, because it can sometimes pick up new PI3 kinase mutations that may have evolved since the last opportunity to do a tissue biopsy. So I would probably look at both tissue and circulating tumor DNA, PIK3CA mutational status in this case, treat with Alpelisib with endocrine therapy, whichever you choose at that point. If she does not have a PI3 kinase mutation, then she is still mTOR inhibitor naive, so she could consider regimens like everolimus and exemestane. Obviously, since she has bone metastasis, a bone-acting agent would be indicated, either a rank ligand antibody or bisphosphonate as well.
Perfect. And if she's...
Is it okay if I add one thing real quickly?
Absolutely. Thank you.
So the only thing I would comment on is, if the patient only has 2 areas of bone disease and they're relatively stable, one consideration is what we consider basically oligoprogression, and to do some type of ablative therapy in if we see stability long-term in just a limited number of sites, to offer that, whether that be stereotactic radiation, surgery, depending on the location of the metastatic disease. But we seem to see these patients now that have 1 or 2 areas that progress and all their other disease is quite stable or responsive, and that is certainly a consideration as well.
Thank you so much, Dr. Paul. That's so important.
I agree. I've done that in my own practice. That's absolutely true. If it's subtle progression and bone only, especially, then treating the involved area locally, followed by continuation of the same CDK4/6 inhibition, may be also worthy as an option.
Dr. Pegram, if I might just ask you, if the patient, for example, was found to have, in the rare event, the patient was found to have a deleterious BRCA mutation and a PIK3CA mutation, what treatment would be your preference in terms of next systemic therapeutic option?
Oh, that's a very difficult question. The pivotal trials of the PARP inhibitors were done in the first line. And so how they would extrapolate following CDK4/6 inhibition with a SERD drug, fulvestrant, is unknown. I would probably feel more comfortable treating the PI3 kinase mutation first and maybe save PARP inhibition for a later line. I know PARP inhibition responses in later lines is not as robust as in first line as well. So, that may reach the point of diminishing returns, but at some point I would try it if you knew for a fact that she had a germline BRCA mutation. But it could be one of those equipoise situations where you could consider both options with the patient at the time of the next progression and let the patient weigh in based on expected toxicities, for example, that might have the patient favor one approach versus the other.
Okay, perfect. So in summary, we would recommend making sure the patient has comprehensive genetic testing, assessing the tissue for PIK3CA mutation based on those test results, consideration of circulating tumor DNA results as well, and then consideration of targeted therapeutic options if those are available to us, and then also an mTOR inhibitor with an aromatase inhibitor as an additional therapeutic option, as well as some targeted radiation therapy if there are only 1 or 2 isolated areas of progression in the setting of otherwise stable disease.